don't even get me started on that. I am going to say we need to be suspicious of things that have acronyms. That's all I'm going to say. And all I will say is I was interviewed by CBS News on some of these therapies, if you want to call them that. And this is not a good look, Nicole, when CBS News with Gayle King is coming to your office to interview you for 2 days on therapies that patients are undergoing. It's not a good look for our profession at all, because it's not to show how amazing dentistry and interdisciplinary therapy is, how we can improve the lives of patients. It's about what are professionals doing to rip off people and ruin their lives. This is nonsensical. It's zero science. I would just say there is a limit to how far we can expand the dental alveolar complex. People that are out there just trying to tell others that you have an airway problem and we're going to expand your arches and we're going to improve your sleep apnea by putting something in your mouth and we're going to just expand the arches without testing, without having data, and without having a periodontal conscience or a biologic compass of where they're headed with treatment, are doing a disservice to patients. They're causing the public to question the integrity of our profession, which I have a big problem with. What has been done to patients with these therapies is unthinkable, and it has ruined the lives of people that we are now having to take care of. And we're into lawsuits and all this other stuff. It didn't need to happen. You can't expand your way out of an AP problem just by using certain devices to expand arches and think you're going to fix sleep apnea problems. There's not one study out there that can support this. It's just people with gravitas or with a strong personality basically saying something that is fallacy, is ridiculous. When we talk about dental expansion, it's about pushing the teeth out and press forward, increasing the outer circumference. When we're talking about skeletal expansion, we're not so much talking about removing the teeth. That will generally come along down the road, but we are talking about actually increasing the size of the maxilla or the mandible, actually changing the form of the skeleton itself. We go trying to move and push the teeth outside the limits of orthodontic tooth movement. There's only so far we can go. These growth guidance appliances, definitely very effective for young individuals, and we can catch somebody early during growth for sure. But if you have a 40-year-old who's got some sleep apnea issues and you're just going to put dental devices on the teeth and expand everything, we're asking for problems. When we talk about tissue engineering, what I'm referencing is guided bone regeneration therapies. When orthodontics expands the arches and creates all these dehiscences everywhere, we're trying to create periodontal regeneration. The vertical growth, this is the problem. Short ramus height, long face. The studies are there that show these patients start with less bone, they end up with less bone, and they're higher risk for root resorption. When you have a vertical grower and you've got some significant decompensation movements to be doing, you need to be thinking about changing the bone morphotype around the teeth so that they don't end up with periodontal problems down the road. I can't tell you the number of patients that I've seen overexpanded, these vertical growers, they have root resorption problems, and now they're at risk for tooth loss. And now this is a complex patient to then reconstruct. If they have thin phenotype, you're going to end up with problems. If they have a thick phenotype, then depending on how far the tooth is going to be moved, you have a less risk of having that problem. So that's how we think about phenotype. It's so important to have a good myofunctional therapist on the team, because a lot of patients do have these myofunctional problems. If somebody is always tongue thrusting, they're going to be moving their tooth forward. The tongue is the strongest organ in the whole craniofacial system, bar none. And if you can't get a handle on the tongue, it's going to move the teeth. It's going to tip the tooth forward. It's going to do orthodontic treatment without having braces on the teeth. And it's basically going to push the tooth through the bone. It's going to also compromise the occlusion, which may impact the stability of the joints. As periodontists, we need to look at tongue posture, open mouth posture, scalloping of the tongue, all these types of things to see, does the patient have some dysfunction here that we need to get a myofunctional therapist on the team so that our results are going to be stable. At the end of the day, if you have a good occlusion, proper space, a good foundation, good tongue posture, a good airway, the function should negate the relapse. Those patients actually may be skeletal patients because maybe they have airway problems, to be honest with you. The orthodontics is essentially camouflaged that fundamental disharmony. Certain patients need to have surgical support for retractive orthodontic therapy. The arch forms are narrow. The real question is, have we set these patients up for all these years for sleep apnea problems? because they've got constricted oral volumes, they have nowhere for their tongue to go but back, and now they have a systemic health problem. At the end of the day, it impacts somebody's quality of life, and perhaps it's their life expectancy. We're all here for the patients. We're in an era today that we can just do so many incredible things. We just do the right thing, work with the team, and use our biologic compass and our periodontal conscious to make sure that we're doing right by the patient. We're very privileged to do what we do, and we have to respect that.